I kept the V3 exposed so you can tell. The V3 goes where exactly? It goes more anterior oriented, right? The whole trigeminal goes more anterior. So it's going to the front, right? So this is the front. And therefore this is the back. The patient on his side, this is a subtemporal approach. So this is either is this the left or the right side? Well, it is the left. Okay. Yes. So does anyone know this foramen? It's a well-known foramen. It is.
It's a structure that is being cut in order to reach this approach.
Exactly. Yes. Does anyone know this structure? We just mentioned it. It's very important. Exactly. Correct. Okay. So does anyone know? We spoke about it, but I just want to reorient it to the surgical field. So does anyone know this eminence? Does it mention it? It's the arcuate eminence. And then there's this the person. Then the cochlea should be somewhere around here, and trigeminal depressor should be here because it's lifted. It's not in its original position. Okay, so there has been some drilling here. The petrous apex has been drilled. So just wanted to first of all let you imagine the relationship of the carotid to the greatest petrosal. So it's exactly behind it, immediately medial to it. Before this, yeah. So
just hide it and just.
So whoever saw it, what is this structure? What is this structure? Yes, he said something like. No, it's actually the what are the internal hereditary meatus. Okay, so the anterior petrosal. We'll talk about this in a minute. But when you remove the apex, you're usually limited by the meatus, the internal auditory meatus lateral. Okay, so this is just to reiterate on the relationships with the underlying structures. So this is the internal auditory meatus, as we said. So it contains all of our precious nerves, and it reaches as soon as it becomes lateral to the cochlea. It gives us the greater superficial petrosal nerve, and it turns out the tympanic part of the fascia. The cochlear ends in the cochlea, and this one and the vestibular superior and inferior, they both go to the semicircular canals. Okay, so
just go to the previous picture. I like this picture is very great. It's going to help me with my next presentation. Okay, so the cavernous triangle.
I've not reviewed recently.
The cavernous sinus triangle. There is multiple triangles, landmark triangle that is very important. Well, actually, to be honest with you, they're kind of useless, most of them. But because in the past, people get to go through the cavernous sinus many times, so they have to know all these cavernous triangles. But now there is few triangles that people still use it, and it has an important anatomical landmark. So, okay, so here we have. So this is the foramen valve, and this is the V3 mandibular, and it's crossed by the GSPN. Okay, so this one is called a triangle, and this is another triangle. Anyone know the names? Okay, can you be more specific? What is Glasgow? What is Kawazi? Okay, so what is Kawazi? This one or this one? This one? Yes. This is Kawazi. Okay, and this is Glasgow. Okay. Okay, what's the importance of Glasgow? What? In the past, people, when they used to do crazy skull-based approaches, and they do occlusion and they do bypass, when they want to have a proximal control, they used to do the proximal control from Glasgow. They drilled the bone here and they found the Petrosal and they put a clip in order to have a proximal control. So that's the only importance for this. For Kawazi to some degree, it still has some importance because when you do middle fossa approach and you want to reach the posterior fossa, you have to drill the Kawazi in order to reach the posterior fossa because this limb of bone, it's going to lead you to the posterior fossa. Okay? I just like the picture, so I thought I just want to describe it.
كويس دكتور ما حركت المحاضرة كانت لو كملت كان خلاص راحت المحاضرة كلها.
That's good. Very nice picture. Okay, so do you want to...
Okay, so we'll proceed. So when we go to because this is mostly circulating around the petroclavian meningioma. So this is an important factor to think about is this angle. It's called the petroclavian angle. And the importance of it, it relies mainly, as I will tell you now after in a minute. We also have the intermeatal plane. So this is the internal auditory canals. There's a line between. And in the center, we measure this. It's called the midline clavicle depression. So whenever you have an angle that is more obtuse, that means you have lower clavicle depression. So this means that you need less invasive approaches to reach the clavicle region. But if we have a more acute petroclavian angle, you will be limited with the natural structure of the region, and you will have to end up doing more bony work than you actually intended. So the failure zones, as Dr. Faris mentioned, the zone 1, which is by the intermeatal plane, and zone 2 is the interjugular frontal plane. So anything that's above zone 1 can be tackled with a subtemporal anterior petrosectomy. Zone 2 you need to come from posterior in a pre-sigmoid approach, and zone 3 is considered more or less foramen magnum, as you see here. So it's attacked by a far lateral approach, which is beyond our scope in this lecture. So generally, in position. The position is usually you have to tilt the head almost 90 degrees from the ground, and we have to tilt it a bit backwards so the zygoma becomes the highest point. And you want the root of zygoma to be the highest point because this is where your interest is. And your skin incisions, whether you want to do posterior or anterior, it's the same. You start from around the mastoid. You don't need to go very low if you want to do only an anterior approach, but you have to go even at least 2 centimeters below the mastoid if you want to do a posterior approach. And your extent towards the anterior, you can stop here or you can go down if you want to do Uzi variant in order to get a better angle, more direct angle of vision. So after you do the incision and do the craniotomy, as we will show, this is what Dr. Abdulaziz mentioned, the 2 triangles. And just to mention, because the glass cock is the triangle where the horizontal component of the petrous part of the carotid artery is there. And as he mentioned thoroughly, it was used before as a quick axis for bypasses and occlusions. Quasi-triangle, it is bounded by this eminence that we mentioned. This is why I reiterated many times the arcuate eminence is one of the most important landmarks of this triangle. It is also bounded with trigeminal, and from this side we'll have the greater superficial petrosal nerve. This triangle encompasses the internal auditory canal, so we have to know that it's just not the whole. It's not just the drilling site only. It also encompasses part of the roof of the internal auditory meatus. Again, I think that lots of pictures are the solution for these topics. So this is also another picture which shows the greater superficial petrosal nerve. This is our arcuate eminence. We should have the superior semicircular canals underneath, and approximately in this region, we should have our internal auditory canal. Generally, if you want to know where the internal auditory canal, you draw a line between the greater superficial petrosal and a line along the arcuate eminence, and it should usually bisect it there is a variation, of course. Sometimes it's more towards the arcuate eminence, sometimes a little bit more towards the other side. But generally, this part here is where you want to be drilling if you want to reach the posterior fossa through a subtemporal approach. The petrous part of the internal carotid will be just medial and below the greater superficial petrosal nerve. So a proper quasi approach should show the internal carotid artery. So this is where some drilling has been done, and we can see the greater superficial petrosal nerve as it crosses the V3. And here we have the area of the arcuate eminence. Here we can see the nice, they have drilled the roof of the internal auditory canal, and they have partially drilled the quasi triangle. You can see the redness of the ICA underneath. Okay, so this is actually one of the initial publications of Quasi himself, where he showed the picture. His description, nowadays you will see most of the description, they will tell you, look for the GSPN V3 and then look for the superior petrosal sinus. This is the classical word, certainly. But the way he described it was more of a structural description. So he mentioned the area of the pyramidal section is surrounded by trigeminal depression anteriorly, eminentia arcuata, arcuate eminence posteriorly, the major petrosal groove, which is this, which is more or less where the greater superficial petrosal nerve passes laterally. Carotid canal, internal auditory canal are all inferior to your drilling site. And he put this picture because it was general idea. If you want to do anterior petrosectomy, this is your craniotomy. If you want to go posterior, you do here with some mastoidectomy as well. We'll come to this in a minute. Again, this is his first classical paper. He showed this incision with the temporal craniotomy, not reaching the posterior fossa, but reaching just above the petrous bone. After bony removal, you can see the apex right here. The dura is still not yet open, and he's just showing you the arcuate eminence with the semicircular canals underneath, and the GSPN is going right here. Of course, as Dr. Baid mentioned earlier, when lifting the dura, you will definitely have to cut the middle meningeal artery after coagulation in order to get a proper elevation. Another important point is when elevating the dura, there is a high chance if you're dissecting the dura anterior to posterior that you might cut the greater superficial petrosal nerve and the patient will lose lacrimation. So therefore, you would have to start posteriorly, reaching the arcuate eminence, and then go your way anteriorly to prevent cutting of the greater superficial petrosal nerve. And after drilling of your petrous apex, here he drilled it and he showed the tumor directly within the petroclavian region. He started cutting the dura. First cut was just above the superior petrosal sinus, and then he followed with horizontal cuts, first lateral to the tumor, and then he cut the dura, roofing the trigeminal nerve in order to reach the tumor that was going there as well. So it was really ahead of its time then, but nowadays it's common knowledge. Okay, so this was what I was going to cover, the anterior petrosal. I will go now to the posterior petrosal. Again, it's more or less the same position, more or less same incision, but your craniotomy will start, you have a bit of a posterior fossa craniotomy and some involvement of the supratentorial craniotomy as well. You will do a mastoidectomy, and then you will generally try to expose the semicircular canals, the bony labyrinth in general. Your dural incisions will be, because the whole idea of this, it's a pre-sigmoid approach, so we want to have a look at this area. So we want to do dural cuts from and above and below the sigmoid sinus. You should skeletonize the sigmoid sinus all the way down to the jugular bulb, so you can easily mobilize it posteriorly. Of course, you will have the sino, this this is superior petrosal sinus, you would have to sacrifice that in order to push it posteriorly. But also importantly, you should not cut the vein of Labbe. Otherwise, you'll have a massive venous infarction. So this is another picture. I'll just show you after the bone resection. This is his area of drilling. Usually, the spinal pendulae is a marker of the antrum, so we don't want to go to the tympanic cavity. Because might lose hearing, especially most of the approaches are supposed to be hearing preserving. Okay, after drilling, posing the sigmoid sinus. So this part of drilling is in a triangle called the Trotman triangle. The Trotman triangle has easy boundaries. It has superior petrosal sinus superiorly. It has the sigmoid sinus laterally, and it has the semicircular canal. So this triangle, whenever you're drilling through it, it should not be, nothing should happen to the hearing, and it should be the first intention towards a retrolabyrinthine approach. Okay, so here he continued the drilling. He de-roofed the facial nerve, showed the lateral semicircular canals, and then followed it with all of the semicircular canals. Now you can see the superior petrosal sinus. Next step would be to dissect it and open the dura, dissect it, and then take it posteriorly in order to the whole target of the support is to access this part of the skull base. So after that, now this is the variations that we'll talk about. So first of all, retrolabyrinthine approach. Here, semicircular canals all should be intact. Nothing should happen to hearing. Facial should not be manipulated a lot, so it should come out with, it's considered lower than the rest in terms of morbidity. Transcrucial, which means that he will go through the common cruce of the semicircular canal, so he will remove all but the lateral semicircular canal, and he will plug the stumps in order to maintain the integrity and function of this labyrinth. And these patients, many of them, they preserve hearing if the plugging is done perfectly. After that, the translab approach, which means you remove the whole labyrinth, and the transcochlear, which means you remove the whole cochlea. Now, if you see here, you'll see the facial nerve is still in its track here. We know that the facial will go to the geniculate ganglion, from there to get the superficial petrosal. But here it's being moved posteriorly. The way to do that is to cut sacrifice the greater superficial petrosal nerve. Of course, you have to unroof the whole facial nerve from the stylomastoid foramen all the way to the internal auditory meatus. Fortunately, because most of the vascular supply to the facial nerve comes at the area of the ganglion, geniculate ganglion. So doing this approach will most probably end up with facial palsy. 30% of the patient after 1 year they might have Anhausen-Blackman grade 3, which is just a little bit of eye closure, very significant cosmetic anomaly. So now we'll go to the combination of both. This is Nifty's original combined petrosal approach publication. He was doing boreholes just above and below the sinus. Mostly he would be around, first borehole would be below the asterium, the other one would be above the asterium. And then he would draw a line over the superior nuchal line, again, one borehole above, one borehole below. And then he would extend his craniotomy all the way to the zygoma, and almost just like a usual retrosigmoid craniotomy. After that, he will continue with the extensive drilling of the mastoid. He will de-roof the facial, just as the previous image, and the semicircular canals. Dural opening, same idea. Dural incisions above and below the sigmoid. We had already skirtalized the sigmoid all the way down to the jugular foramen. Vein of Labbe, again, very critical to preserve. Actually, there's no real benefit for this, but I really like the images, so I wanted to show you these pictures. So he's doing, this guy will do, I really don't know his name. I got from a website called Neuropsyche. just found it through Google, but I really like the images, so I wanted to show you. So this is his incision, not usually the usual classical one. He went down all the way, like a question mark, with the extension all the way down to the mastoid. After flipping the skin, then he did flip the muscle. He started, so he put this image to show you what is the extent of his bony resection. So he's doing almost like a Kawasi here, and he's unroofing and the rest is basically more or less the same as the posterior petrosal approaches, no difference. And he will start by, again, doing mastectomy, showing the superior, all the semicircular canals, traditional retrosigmoid craniotomy. Then he will follow it with traditional temporal, for the subtemporal. His dural opening is interesting. He has he opens the dural before. That's the thing, because most of these approaches are extradural, but here he seems to open the dural even before. So after opening the dural in this fashion, he will follow it through all the way to the tent, and he will sacrifice the superior petrosal sinus at this region. After putting his retractors, he will lift up a little bit and cut the tent. This is our trochlear nerve at the interior edge. And look at that, very nice panoramic vision all the way from third oculomotor nerve down to the 11th. It's a very nice picture. I really liked it. I hope you did too.
Okay, can I tell you something? Okay, my career so far. Okay, so first of all, this is actually nice pictures, really nice pictures. In my career, for the last almost 3 years, I've just had one petrocladal syndrome, and I did this approach. I did everything mentioned in the book. It sounds beautiful, but once you get inside, it's useless. It's not as easy as it's described like this, but it's the way to go, because petrocladal lesion, this is the best way to approach this, because you want to control the blood supply of the tumor. And by doing this amount of bony drilling, you're controlling the blood supply of the tumor, and this is the shortest way. So I guess it's just basically, you just need to accept the difficulty, and that's it.
Thank you. Okay, so.
Well, I did it in two stages. First day, bone drilling only. Second day, dural opening and tumor removal. 2 full days.
Okay, so we already spoke about the approaches, but I want to elucidate a little bit about the philosophy, the evolution of the surgical approaches. Now, this article is from the well-known Burroughs Center, and they're mentioning their more than 2-decade experience in such lesions. So I'll just read here from the quote I have taken. So he wrote, over time, we have moved away from performing complex transpectrosal approaches to treat these challenging lesions. The retrosigmoid craniotomy with its variations, I will come to that in a minute, have proven to be safe and excellent method to approach the CP angle. The OZ approach will also cover the lesions that are extended beyond the tentorial notch. So here they have group 1, which is the old group, the one that are going through the combined transpectrals, the whole deal approach, and the others who are going with the minimalistic type approaches. And before we mention the results, it's definitely clear that the role of radiation is coming more and more, and it's saving the time and decreasing the eagerness of surgeons to resect as much as possible. And it's really paying off. So if we look down here, which is more or less the most common complications, there is a very significant drop in the percentage of cranial deficit from 17 to 23%. And the overall complications are down from 85 to 33. Definitely. Group 1 are the old school complete combined petrosal approaches. The group 2 are the ones that are treated with retrosigmoid with its variations plus minus OZ approach.
This is meta-analysis or what?
No, it's the whole experience spanning 2 decades of Burroughs Institute.
Okay, this is their own series.
Their own series, yes. Burroughs, yes. So I think there are like 10 people, including Spetzler and many well-known figures. And the last they mentioned that increasing bone removal is not always true for the petrous bone.
Please check this paper with us, please.
Sure, definitely. I'll send it to you shortly. Okay, so now because they mentioned the retrosigmoid, I wanted to know what kind of variation they're talking about. So this is the variation they are talking about. It's initially mentioned by Roten. He's doing, he mentioned the anatomical study basically of suprameatal extension. So if you look here at the image, so this is the petrous bone. This is the internal meatus over here, and the suprameatal tubercle is like a notch that's on your way. There is no structure that's been there, just bone. So, because most of the lesions, their extension is either towards trigeminal through the neck escape. So this was a very common challenge, and most people would turn around doing combined petrous approaches just for a small extension that's going up. So this procedure, this addition, although minute, but it made a big difference. Suprameatal tubercle here, it's been removed. It added 1 centimeter distance of the trigeminal, which was not being reachable with the traditional retrosigmoid approach. Average is 10 millimeters increase in visual. Lowest is 8. The lowest they have was 8. They can reach up to 13. However, there is people who mention that petrous is basically a venous lake. You have lots of venous bleeding. You can see very well you might do more harm than good. Okay, so at the end of the day, what really matters in petroclival tumors are 3 things. If you have a good plane around the tumor, if it has very soft consistency, and if it doesn't involve critical neurovascular structure. This is where it comes to. Doesn't matter which approach you take, as long as these factors are good, you most probably will have a good outcome. Thank you very much.